The Pediatric Lounge, a podcast taking you behind the door of the physician's lounge to get a deeper insight into just what docs are talking about today. From the clinically profound to the wonderfully routine and everything in between. Well, hello again to this week's episode. Please help me welcome Dr. Lee Gross, who graduated from Case Western Reserve University with a degree in medicine and then completed his residency in family medicine at the University Hospitals of Cleveland, where he served as chief resident. Dr. Gross is board certified in family medicine and is also active as a chief evangelist of direct primary care through his leadership in Docs4Care Foundation, DPC Action, and the United States Medical Association. Dr. Gross has testified before the U.S. Senate and many other forums. Dr. Gross also is one of the leaders of the yearly conference for physicians wanting to know how direct primary care works. Please help me welcome him. Hi there, George from Florence, Italy. How are you today?
Hey, how you doing? I'm doing very good, sitting here in front of the Dome in Florence. But, you know, the podcast has to continue, so we always make the time.
And Dr. Lee Gross, welcome to the show. Thank you so much for taking time from your busy schedule today to accommodate this conversation.
Thank you, gentlemen, for having me. Appreciate it.
Lee, I met you a few years ago, and I was very impressed with what you have done in the DPC movement and your advocacy. Could you tell us how you went from family practice to being an advocate and speaking in front of the Senate?
Yeah, so the name of my practice is Epiphany Health, and Epiphany is a really strange name for a healthcare company, but in fact, we did have an epiphany. I had a fully insured traditional primary care practice here in Southwest Florida. I was on the treadmill just like everybody else, running, trying to keep my practice afloat, trying to keep up with all the rule changes with the federal government and the insurers, and continuing to deal with the constant cuts in payments from the insurance company, while at the same time increasing in regulations. And we had an epiphany moment. And the epiphany moment was a small business owner came up to me and my partner and said, everything, all my employees see you as their doctor, and my insurance premiums are skyrocketing. I can't afford it anymore. I see what they pay you, and you're getting ripped off because I know what I pay them. And he said, why don't I just hire you to take care of my employees? And then I'll just take out a major medical catastrophic insurance plan in case anything catastrophic happens to them. And that was our epiphany moment, was why are we insuring primary care? Why are we inserting so many obstacles and so many barriers between the doctor and the patient for the most basic healthcare delivery, and then filing claims for that? And then we're having to code every single one and get upset that it's impersonal, it's inefficient, it's cumbersome, and it's very expensive. And so at that time, that was back in 2009, we built a business plan that said that we created a subscription-based primary care program, much like Netflix, where you pay a flat monthly fee for all the episodes you want to watch. We charge a flat monthly fee for all the services that we can provide in our office. And it turns out that at the time, it was one of the first direct primary care practices in the country. There were other people working in the space at the time, but nobody really knew about each other. We were all sort of working as sort of mad scientists in our garage, coming up with our crazy business schemes. But as far as the advocacy is concerned, one of the interesting things, the early things that came up, is that if a doctor and a patient contract with each other for a defined package of services or unlimited group of services, does the doctor become an insurance company? Does the doctor need to be licensed as an insurance salesperson to sell those memberships? And we very quickly realized that a rogue insurance commissioner very easily could say that you're operating an illegal HMO and come and shut the practice model down. So that sort of got us into the advocacy space, and ended up getting us testifying at the state level, and ultimately dealing with many other complexities of the legal aspects of the practice model as it grew, which ultimately led me to testifying before the United States Senate.
Wow. Now, the DPC model is more than just a Netflix subscription model because, as I understand it, you're trying to not only do great medicine for your patient, but you're trying to keep the cost down for your patient. And so you do every or make every effort uh, to find partnerships such that they get wholesale prices on pharmacy, x-rays, physical therapy, even some specialists. Is that part of the mission?
That was not the intention when we first set up the practice, but that was the necessity of what ended up happening next. Because once we flipped the switch and we created our membership, and our membership right now is $80 a month for an adult, $30 a month for the first child, and $15 a month for each additional child. After that, there's no cost or no charge for anything that we do in our office. It was actually a little more expensive at the time when we first launched it, so we're actually cheaper today, 12 years later, than when we first launched it. But what happened was once we flipped the switch and turned on the lights, we started seeing uninsured patients coming to our practice from all over the state of Florida. So suddenly we had to figure out how to get affordable access to labs and imaging services and physical therapy services and specialty care, affordable access to prescription medications, because we had suddenly developed a massive practice of uninsured patients. And so we reached out to our local imaging centers and said, if I could send you a cash paying patient that would agree to pay you exactly at the time when they had their services performed, and you didn't have to file a claim or get prior authorizations or get the money clawed back 6 months later, what could you sell us an unused MRI slot for? What could you sell us an x-ray for? And we were getting MRIs for $225 and CT scans for $175 and plain x-rays for about $25. Same thing as we went to the laboratory services, so the pathology services, and said, if we agreed to collect the money at the time we gave our patients the order for blood work, and then you sent us one bill for all of our patients at the end of the month, instead of trying to collect from every single individual patient, sending bills to their insurance, applied towards their deductibles, having to take discounts and matching up codes, what if we just did it all real time? Well, it turns out when you talk to the labs and you ask them, what's the most expensive thing that you do? Their answer is the most expensive we do is interact with patients' insurance companies and third-party payers. The human labor associated with billing and collecting insurance was the most expensive part of their operation. Providing the laboratory services and the performances of the medical care was the cheapest thing. So we were seeing 95% discounts on lab services. So we'd get $2,000 worth of labs for about $80.
Wow.
And just the standard blood work we need to manage a diabetic patient, quarterly labs, a lipid panel, a complete blood count, a metabolic panel, an A1C test, a thyroid TSH, an A1C, that's $45. And it turns out that the prices we were getting for cash pay was actually cheaper than our patients that had insurance were getting for their copayments. So it was actually more expensive to pull out your insurance card and use your insurance than it was to put it in your pocket and pay cash using our pricing. And I will tell you again, 12 years later, our costs for imaging services are nearly identical than they were 12 years ago. Our costs for laboratory services are nearly identical to where they were 12 years ago. So we are not seeing this massive skyrocketing cost of healthcare services within our practice. We're seeing a massive skyrocketing of healthcare coverage costs and hospitalization charges. But the actual cost of the routine outpatient care is very affordable.
Well, and there's two other models. One's in the Midwest. It's a surgical center, right? They give you everything is this price. I'll do your hip, anesthesia, everything is this price, and very successful. And there's a huge one that big employers will use on campus. Forget the name of this company, but they're all over the country. They've been around for 25 years and very successful, doing exactly the same. The employer just goes, here, manage my primary care, and it'll be a lot cheaper than having insurance. And we'll just have the insurance for the catastrophic and the specialist. What is the difference between a DPC model other than you're really looking out for the patient? You're looking to make sure their cost is always maintained as low as possible with great care. But say DPC versus someone like One Medical, where they take insurance And on top of that, they charge you $200 a year to be a member.
Yeah, so I haven't done a deep dive into the One Medical business model. Obviously, One Medical was just sold for, I think, over $1 billion to Amazon. That sale has not actually gone through yet, and it's unclear whether or not it is going to go through now that Amazon just announced that they're folding their Amazon Care business after 3 years. But from as I understand it, they're not really direct primary care. They're more of a concierge practice where, as you mentioned, they charge a membership fee, which gives you added access to services, priority visits, longer visits, maybe a proprietary blood test, but they still charge an insurance company fee for service for everything that they do within their practice. So I sort of equate that to paying for the fast pass at Disney World. Everyone pays a price to get in the door, but some people are more special than others or get to the front of the line faster if you're willing to pay for it.
What I don't understand is, I thought I'm pretty well versed in the insurance industry, but I thought you were not allowed to bill a patient extra money for services that you should be providing anyway, like access, just office visits, and so forth. How is that possible? How is that legal?
Yes, so they specifically designed that for, we're going to charge for non-covered services. So they operate in this gray zone of services that are not typically covered within the insurance plan. And the problem is, as the practice of medicine evolves, those areas that were typically non-covered services are now kind of covered services. So a telemedicine visit maybe 10 years ago was clearly something that's not covered by most insurances. They wouldn't pay for a telephone call or a technology visit. Now they all do. And so to charge extra for access to the doctor's email address is probably not acceptable. It's no longer a non-covered service. To charge for, again, technology, the extra technology visits, the priority appointments. So the way companies like MDVIP do it is they will charge for a physical for a Medicare patient. So as you know, Medicare pays for an annual wellness visit, which is not a physical. And so they bring in for proprietary physical. They do things that are not covered for prevention by Medicare. They will build in some very expensive advanced lipid profile, maybe some proprietary test out of Cleveland Clinic or whatever, and they'll charge $10,000 for that visit.
You gotta be kidding.
And that'll be sort of divided over the course of the year, and then everything else is standard bill. So that's kind of the concierge model. Again, is covering non-covered services. I think that gray zone will continue to keep getting narrower and narrower, and eventually, I think it's going to probably squeeze the companies that are doing that to where the business model is probably not sustainable. The other thing that One Medical does is they enter into shared savings agreements with Medicare managed care companies. So they will contract with United Healthcare and say, we will manage this population, and if we save you $40 million, we get 5% of that. And so they will structure their practices in such a way that they can try to lower costs, and it's sort of a shared risk program that Medicare kind of likes. But again, it's not direct primary care, and the cost savings are, I think the cost savings in the direct primary care side are far superior than what they've seen in the ACO settings.
So as pediatricians, we have constant problems with reimbursement. I think family practice is not too far ahead of us, but we're way below on the payment scale. And for some reason, the political class values the life of a child at 50% of that of an adult. A lot of Medicaid plans across the country barely pay 50% of what Medicare pays on the Medicaid, and that's 51% of the patients. So our audience is very interested in advocacy because we feel that no one's really advocating that it's just morally wrong to say that a physical for an infant has the same RVUs than a 99213, and that it can be paid 50% of what it would be paid for a 65-year-old. How did you get so much advocacy out of DPC Action and Docs4Care, because you guys are not a huge medical group. You're not the American Medical Association. You're not, the American Academy of Pediatrics. You're not the American Society of Orthopedic Surgeons. How did you get these two built up and all the way into the Senate without having a huge budget?
So we took a completely different approach. So when I was fee for service, I would do, my advocacy was just like everybody else, where I would go up to Washington, go door to door in the halls of Congress and beg members of Congress for more money. We would ask for a bigger piece of the pie. We'd always walk in with our hands out, saying, don't cut our pay, please, please give us more money. Our costs are skyrocketing. And then as soon as we left, the surgeons would walk in and say, we need a bigger cut of the pie. And then the radiologists would walk in and say, we need a bigger cut of the pie. And the insurance companies would walk in. And what we realized is that no cavalry was coming from Washington to save our practices and save our patients. It just wasn't coming. And so we said, we're just going to fix it ourselves. We're not going to go back to Washington and beg them for a solution. We're going to fix it ourselves. And the next time we go to Washington, we're going to tell them how we fixed it. And then we're going to tell them how they can help us continue to fix it. So instead of going back to Washington with our hands out asking for money, we went with our hands out with a handshake saying, we're here to help you. We don't want your money. We know you don't have it. And these are the solutions that we've put into place. These are the ways that we feel that they're working. And we found a much, much more receptive audience. And so you don't need to go in with a big checkbook and write a campaign check when you're coming in with solutions. And before you know it, they're now sending us model legislation to review to put in our pieces that we need in order to expand the practice model, because they're looking for solutions. And the other thing is that, while there's constant brinksmanship at the federal level, at the state levels, these people need to solve their problems. They have to fix things. And so we found state legislatures much more receptive at fixing problems and implementing solutions than the federal level. So we went to our state lawmakers, and we now have passed protective legislation in 31 states. We're working on Medicaid pilot programs in multiple states. We're working on pilot programs where for state employees
So let
there's
me,
lots of
because I'm a big fan of yours and what you've accomplished. But when you said we're working on pilot Medicaid programs, what does that look like, and what states are you doing that in?
Yeah, so I don't want to put the cart in front of the horse, because these are private conversations with folks within various state governments and governors' offices and so forth that have reached out to us for assistance. So we had originally drafted one that passed in the state of Michigan. That one was starting to get away from us before it got launched, and so we pulled the plug on it before it got too off the rails. But I'd love to share a little bit about what we're doing in some rural healthcare settings, because I think that is probably some of the most outstanding accomplishments that we've seen. And in fact, I think our case study that we are working on with DeSoto Memorial Hospital is probably one of the best stories in healthcare today. If you have time, I'd love to share kind of that work.
Yes, I would love to hear that.
Yeah, that would be great.
So as you know, more than 100 rural hospitals in the last 10 years have shuttered their doors because of the financial pressures on rural healthcare. The Medicaid payments, as you've alluded to, just don't keep pace with the cost of providing care, and rural healthcare and hospital care is largely financed through the Medicaid program. So they're all kind of sucking wind. And again, the federal government paints with a very broad brush. So when they pass these regulations that may not have a massive financial impact, say on Manhattan, but in rural America, trying to implement those same regulatory requirements on a hospital that may only have three to five patients in the hospital, just don't have the financial resources to comply with those sorts of requirements. So you mentioned the Surgery Center of Oklahoma earlier that has bundled cash prices on surgeries. There is a rural hospital about an hour inland from my practice here. It's in Central Florida. It's a DeSoto Memorial Hospital. It is the second lowest income per capita county in the state of Florida. So it's a relatively low income community. And DeSoto Hospital reached out to me after hearing me present our story for the governor of Florida and said, we love your model. We would love to offer you bundled cash surgical prices for your patients, very similar to Surgery Center of Oklahoma. And so we sat down with the management administration of the hospital. We designed bundles for things like colonoscopies, hip replacements, knee replacements, shoulder surgeries. And interestingly, we started seeing uninsured patients coming into this rural hospital from all across the state of Florida. We would see patients from Miami driving through rural Florida to have a colonoscopy done in the middle of the state because the colonoscopy is $1,200. The pathology services are bundled in, so they're not going to get a surprise $3,000 to $5,000 pathology bill after the surgery is done. They're not going to get a $5,000 upfront charge for the colonoscopy. They don't have to worry about whether it's coded as screening or diagnostic and whether it's applied towards the deductible or whether it should be free. It's a cash price. So if I were to go down the street to the HCA hospital up the road, and I'm not picking on HCA, I could pick any, but if I went to the HCA hospital and I needed a knee replacement, they charge $150,000 for that surgery. We can do that surgery for $18,500 at DeSoto Memorial Hospital. So if I'm a self-insured employer, why can't I incentivize financially my employee to get a surgery done at DeSoto Memorial Hospital, maybe even waive the co-payments, waive the financial responsibility, maybe even pay for them to go there in order for the plan to save $130,000 and maybe even split those savings with them. And so that's exactly what we started seeing from the self-funded insurance world across the state of Florida, starting to drive volume to this little hospital. So this little hospital that's used to seeing people from their community leave the community for medical care, that's where grandpa died. You don't go to that hospital. But now all of a sudden they're seeing people from 2, 3, 4 hours away driving into their community to get quality, affordable medical care. That changes the perspective of the hospital in the eyes of that community. And even just driving up margins of surgical volume 3 to 5% on a hospital that has such a tight financial margin is huge. So that process played out over a couple of years, and eventually we sat down with the leadership and said, why don't we build this into your employee health plan and take the same principles? Because as an employer, human labor is their number one expense, but number two is their employee health plan. So they were already a self-funded insurer, but they were self-funded through a commercial third-party administrator, TPA, that managed their claims. And we brought in Carl Schuessler from Atlanta, benefits advisor out of Atlanta, and we completely redesigned their entire employee health plan and made them independent. So we took them away from the commercial carriers. We eliminated their networks and we eliminated their deductibles. We reduced their premiums. And if any of them signed up for direct primary care, it was free to them. It cost them absolutely nothing. If they had any services done whatsoever at the hospital, it cost the employee nothing. So if you get an MRI, if you get a CT scan, if you get blood work, if you have surgery done, zero copays, zero deductibles, it's free to them. With the direct primary care component, if they signed up, primary care was free to them. We're now 3.5 years into that. We've saved that hospital's employee health plan by over 50%. We've saved them millions of dollars over 3 years. And that's only with 200 employees signing up for the DPC, or 200 family members signing up for the DPC. Their employee premiums dropped 20% in the first year, and they have not gone up a single nickel in 3 years. So we've seen a stabilization. The hospital has a stop loss insurance carrier. So the hospital is insured for major losses as the insurer. And so the hospital itself has actually seen a reduction in their own reinsurance rates because the claims history is so incredibly low. So again, we took a hospital that, much like the rest of rural America, that was having financial crisis, and flipped it around. So this hospital is now having its best financial history, best financial years in its history, and is now hiring full-time physicians, expanding service lines, and now all the employees are getting their care at this hospital itself. So while the hospital is still spending money on healthcare, they're spending money to itself, because 80% of the healthcare that the employees are getting now are getting at the hospital itself, where before we stepped in and did that, 80% of the care was being provided by somebody else. So the hospital's taking money out of its right pocket and putting it into its left pocket to provide care for its own community. So
and not only,
you know what's interesting to me? You're sounding like you should be a hospital administrator, but I don't think you are a hospital administrator, right?
No, I am not a hospital administrator.
But
yeah,
well,
isn't that the job? Isn't it the job of the hospital administrator to do deals like this?
Well, I mean, kudos to this hospital administrator that reached out to us and was willing to take the risk and make it happen. So I sat down then with the superintendent of schools of this community, because they sit on the board of this hospital and they see the success of it. And as you probably see in your communities, the way employee health plans now are structured is if the employee signs up, it's usually very affordable because the health plan is largely subsidized by the employer. But if you had a family member, it's full freight. I mean, the employer is usually not kicking in for the family member. So the teachers at this school may pay $90 a month for their health insurance. But if you add a spouse, it goes up to $1,200 a month. And if you add a child, it goes up to $1,500 a month. No teacher can afford $1,500 a month in health insurance that has a $1,500 deductible. And so superintendent, we sat down with them and we explained to them how the health plan works at DeSoto and how, because we're independent, it's a lot more hands-on. And his answer was, I don't want to be hands-on with my employees' health plan. And I asked him the same question. I said, what's your number 2 line item cost in your school system after labor? And he says, our health plan. I said, why wouldn't you want to actively manage your number 2 line item cost in your budget? That seems like that should be the role of a superintendent. Well, so that now they're looking to offer direct primary care memberships to all the dependents within the school board and school system. We're going to save them millions of dollars as well.
So not only are you benefiting the hospital and many patients, but also for every dollar that's spent in that hospital, that rural community seeing a 7 or 10-fold return in money spent in the community. So it really does impact the ability of the community to grow and sustain itself. It's a beautiful model.
If you think about something like the school board, I mean, they're seeing 10 to 15% insurance premium spikes every single year. That's money that's leaving that community. That's money that's not being spent in the schools. That's money that's not being spent in wage increases. It's not being spent at the community. It's all going to, some insurance company up in New York City or up in Philadelphia.
Wow,
but it's not going to Main Street America.
No, that's a beautiful story. Thank you for sharing that. That's very, very nice. Now, I have some questions about DPC. Can DPC work with networks, not insurance networks, but a group of physicians networking together in a DPC model, like a group of pediatricians?
It can, and it is in many communities. And I think you just have to be careful on how those are structured, because we have some networks around us here in Florida. I think especially if you're trying to work with employers, they're going to kind of want some networks. They're going to want to say, hey, which primary care doctors can I choose from if we build this employee health plan around it? But some of the network contracts I've seen are as bad as some of the HMO contracts that I signed when I was doing fee for service. They have non-competes. They have proprietary software platforms you have to use. So I think as long as the doctor is setting his or her prices, the doctor determines the care that's provided and the level of care that's provided, and that relationship is as pure as possible between the doctor and patient without some third party in the middle of that relationship, the better it is. And the more you start to insert obstacles, the trickier it gets. So back to my DeSoto model, one of the beautiful things that sort of keeps that pure, even though there's a third party paying that DPC bill, is we have eliminated all requirements for prior authorization, step edits, formulary exemption requests. And so the plan is built so that if I order a test, it's automatically approved. If I order a medication, the formulary says Dr. Gross ordered this medication, therefore it's paid for. But if you create networks and then you have to have network administrators and so forth, it can get just as complex as the system we're trying to fix.
And what are your thoughts on pediatrics and DPC? Because the rub there is, ACA said your well-child exams have no copay, and the vaccines are very expensive, and nobody wants to be seen in my office and then go to the health department to get the shots.
Right. So the vaccine issue, in my experience, is the biggest obstacle to DPC uptake by Pediatrics. As you know, that early vaccine series costs thousands and thousands and thousands of dollars. It's not an inexpensive proposition. And a practice, a small DPC practice, you could easily have $30,000 in vaccines sitting in your refrigerator.
Right.
And if you don't have the volume, those things go bad.
Yeah.
And the other challenge is that if you are DPC, then usually by definition, you're opted out of insurance contracts. And many insurance companies will not honor you submitting a claim for a vaccination because you're out of network.
Correct.
And so we're working in some states with legislation that basically says that even if your primary is not out of network, these pediatric vaccines that are covered by them have to be covered. If you get them, that's something that's working on in Maine. There are some workarounds that we've seen in the DPC world are that the doctor will write a prescription for the vaccine, have the patient fill that prescription at the pharmacy, and then bring the vaccines to the pediatrician's office for administration. So the pharmacy bills the insurance company or Medicaid for the vaccine, and then there's no administrative cost from the practice side. And of course, you mentioned the health department, which is far from an ideal solution, and it just overstresses an already burdened health safety net.
Yeah.
The other challenge with DPC is in pediatrics is getting that price point right. So I mentioned that I charge $80 a month for an adult and $30 a month for a child and $15 for each additional child. There's no way on earth a pediatric practice can survive on $30 and $15. That's just not reasonable. It's like asking a restaurant to survive on the kids menu. The reason you can sell the kids menu cheaper is because you have adults paying full price and sort of subsidizing that. And the reason that I can charge so little for the kids is because I have adults, paying adult members. That is where we make our money. So the price points on pediatrics are going to be far greater than my pediatric price points, and then they have to be. And then that's a matter of then does do the parents see the value in that price point? And that's where you're sort of straddling that line of, am I a concierge pediatric practice? Do I have a niche market? So I have a DPC pediatrician right next to my office here, and he's a neonatologist, and he deals with patients that have been discharged from the NICU, and that's basically his sole practice is flat monthly fee for managing complex post NICU babies.
Well, I
he's not
think
charging $30 a month for it.
no, but I think depends. A lot of people with good jobs here in Northern Virginia, they're paying $18,000 to $25,000 a year for insurance for their family, and they have a $5,000 deductible, and they tear their hair out because they don't know what it's going to cost to go to the doctor, because you got to wait till the Blue Cross Blue Shield says how much they're going to be charged. Right. And they're like, why don't you just charge me a monthly fee? I just want to be able to come and not worry, get a bill later. It's just so archaic and complicated.
Well, so for example, when you're billing the insurance company and you're bringing the child for a well child check, and they say, oh, by the way, while Johnny's here, Johnny has a sore throat. Do you mind looking at his throat? And so you do a strep swab or whatever, and they think it's a free visit, right? Because it's a preventive visit, but you have to bill it as two separate visits. You have to bill it as a wellness visit, and then you have to bill it as an evaluation of management of a sore throat, and you have to bill out the strep swab. So all of a sudden, this free visit, they're getting a $200 bill in the mail for their responsibility, and they're mad at you because you coded it wrong, right?
Right.
This was my free visit. And so it creates this anger and this frustration between the doctor and patient because you're billing it the way it was supposed to be billed. And now once they've been burned by that once, they're not going to bring up the sore throat in the next office visit. Or they're afraid to even mention anything that's bothering them. In the DPC model, that means nothing. You talk about whatever you need to talk about in that visit. It's your time. There's no surprise bill coming because, hey, oh, by the way, I twisted my ankle last week when I was playing soccer. Can you take a look at it? And so we solve a lot of problems with the model. Is it perfect? Absolutely not.
And how long do you spend with each patient? Like you have more time with each patient than you would in a regular family practice?
Yeah, so when I was a regular fee for service, I was seeing between 25 and 30 patients a day. Right now, I'm probably seeing 12 to 16 patients a day. I would say a handful of those are technology visits, so they're phone calls or video chats. My new patient appointments are an hour long. My follow-up visits are 30 minutes. My sick visits are 30 minutes. We do same day appointments. So 2 hours of my schedule every single day are reserved for same day appointments. So if you call me in the morning, I see you in the morning. If you call in the afternoon, I see you in the afternoon.
Wow.
You know what? But this sounds an a lot like a capitation model, almost. You heard about capitation, right? Remember?
Yeah, well, I lived
In the
through some
90s?
capitation, sure. And so
Yeah.
in the capitation model, typically the doctor that's capitated has a financial risk for downstream spending. So if I were to refer you out to an endocrinologist, or you go to the emergency room, or you end up in the hospital, I get penalized for those added costs. And so in this model, this is, yeah, I mean, you could say it's capitation, but it's capitation on terms that I've agreed to directly with that patient.
Right.
And so if I were to say capitation with like a Blue Cross, they're going to say, hey, your diabetic patient's not on a statin, therefore you're going to get a 5% pay cut at the end of the year because you're mismanaging that. And in my world, I can sit down with the diabetic patient and say, these are the data on statins. It's recommended that all diabetic patients take statins, and explain all the risk, benefits, and alternatives, and they can choose not to. And I don't personally have a financial stake in whether they do or do not. It allows me to be a better advocate without our arbitrary third-party forces in the middle of that trying to steer it where it doesn't necessarily need to go.
$80 doesn't sound like a lot. I mean, that's less than Medicare.
Yes.
Right.
Yeah.
And
So
people can come in every month.
Yeah. So if you look at the accountable care organizations, rural ACOs, they had 5 years of losses before they showed their first year of savings. And the first year of savings, they showed about $63 per member per month annual. $63 a year savings, and we saved like almost $3,000 for our people. I mean, it wasn't even a fair fight. But yeah, I mean,
pharmaceuticals. That's how we're doing it.
The costs that we save are astronomical, and yes, it's a bargain. Some people can't afford it, and some people think we don't charge enough.
How do you measure quality? Do you even bother measuring quality so that when you're contracting with this bigger, like the hospital or the school system, you can show not only the patient satisfaction, less physician burnout, but we're doing really good with our hypertensive patient, our diabetic patients. How do you show them quality?
Yeah, so every DPC practice is different. I mean, I think one of the reasons a lot of people go to DPC is they're just tired of the bureaucracy and the micromanagement of the practice. I can tell you that when we structured our arrangement with the hospital, we chose to report data for research purposes. So we track our utilization numbers. We report to the third-party administrator diagnosis codes for what we're seeing these people for, so we can track how sick our population is, and then we can track downstream utilization. So we track the costs on, or we track quality on specialty referrals, ER visits, hospitalizations, but we don't necessarily report A1C values or blood pressure readings and the like. We also track it on patient satisfaction in terms of the renewal rate, whether the patients choose to sign up for us again, because open enrollment every year, they can choose to leave and go anyplace else. There are no networks. They can go to any primary care doctor they want with no penalty. And yet we don't have patients canceling our program. They keep signing up. In fact, we have about 30% year-over-year growth in the DPC, which tells you, in a population of healthcare workers receiving healthcare, that they're very happy with the care that they're receiving. So wow. It's quality as determined by the person receiving the care, not some arbitrary third-party metric.
Okay. And it seems to me from everything I've read about you and the conversations we had before, that you're really a believer and advocate for free markets and the strength of the patient-doctor relationship. How can people support that, which is your mission?
Yeah, so I will tell you a very short story. When I first was invited to Washington to present our practice model, somebody had heard about it and said, this is really neat. You mind coming up? We're having a conference, about 100 physicians in the room, and I gave probably the worst presentation I've ever given in my life because I hate public speaking. And I shared our story of Epiphany and the startup and just some of the early work we were doing, which wasn't even nearly as robust as we have now. And the first question out of the audience was a urologist out of Atlanta that said, so you're charging $89 a month, which is what we were charging at the time. So what happens if somebody sets up right next to you and charges $40 a month? What are you going to do? And I said, well, if the first question out of the audience is what's going to happen when you bring down the cost of healthcare, then we're on to something, because nobody has ever asked that question in US history, is what are we going to do when healthcare gets cheaper? I said, but what's going to happen is that doctor and I are going to have to compete on price and quality. And that price and quality is going to be determined by the one receiving the services, the patient. And either I'm going to have to justify why I'm more than twice as expensive. Do I provide better care? Do I have a better resume? Do I have a better pedigree? Do I have more experience? Is it a better practice environment? Am I more convenient hours? Do I provide just better services? If not, I've got to lower my prices to compete, or I'm going to lose all the patients to the doctor next door. And we're seeing that. We're actually seeing that process now playing out as we're seeing doctors up the road. So I had a business that was interested in signing up with a DPC doctor in another community, and that doctor was charging $120 a month. And the business owner said, "Hey, Dr. Gross is charging $80. Can you match that?" And that doctor said no. And he's like, "Okay." And he signed up with my practice. That's a free market. There's competition on quality, competition on value, as perceived by the person paying the bills. So if somebody wanted to support our efforts, my organization is called Docs4Care Foundation. That our website is D4PCFoundation.org. But every year we put on conferences where we teach physicians how to set up direct primary care practices. It's typically a 2.5-day conference where we run through the business model, we run through the legal stuff, we run through the contract structures that you have to do. How do you negotiate contracts with laboratory services? How do you get cash prices on imaging services? And we walk people through the entire process. We give them between 11 to 13 hours of CME. And that is supported by a grant from the Physicians Foundation. Every year we get a grant from the Physicians Foundation to help offset the cost of this. This year's conference is in Dallas, Texas, from November 10th to November 12th. If somebody wanted to look into that, they could go to the website dpcconference.com and look up the information about the program. And we're still setting the agenda, but this year we're doing something a little different, as we're putting on procedural clinics where we're having specialists come in and teach advanced suturing techniques, catheterizations, how to manage nosebleeds and pack noses, and manage simple fractures and that sort of stuff. So things that can avoid specialty referrals for things commonly seen in a primary care office that might otherwise, not have experience with doing those in your private practice.
Are you going to have bedside ultrasound workshops at this conference?
This conference, no. There was just a conference, the DPC Summit in Kansas City. They had a point of care ultrasound program at that one. So we're trying not to duplicate content on that, but those are being done, definitely.
I know I'm biased, but that a meeting that you put is wonderfully orchestrated, and it's a very high level meeting, and it's fascinating the people that are involved and how much thought they've put in and how much experience you bring to that room for those 2 days. I think anyone thinking about going into a DPC model should attend that conference once before they launch their practice. It's a wonderful experience.
I appreciate that. And so when we set up that conference, I honestly expected a bunch of old gray-haired people that were just fed up with the system. They had been beaten down, burnt out, and just looking for something to do in the final years before they retired and actually be able to practice medicine again. And what showed up at that conference was a group of young, hungry physicians just out of training that had already been burnt out in residency. We already burnt out our new doctors in residency, and they're coming out and they're saying, this is not what I thought this was going to be. I need to find something else to do. But I can't work in this system. I can't be a cog on the wheel. I can't be a shill for corporate medicine. I need to be the doctor I wanted to be. I want to be the doctor that wrote that med school essay. And I can't do it in the system, and so we had a young, energized group. This is the future of healthcare. These people are excited. This is the happiest CME conference you will ever attend in your life, with an energized group of people, not a bunch of curmudgeons complaining about how it used to be and how bad it's getting, and oh, the hospitalists, and oh, no, this is, ideas and excitement and exchanging and helpfulness and not competing, but hey, call me, I've got an idea for how you can grow your practice. Very exciting.
I will say that is what you're describing is true. From the speakers to the people on the tables to just the people in the hallways, the energy is great. It's a high energy meeting. It's a wonderful place to be. I wanted to ask you real quick before I take too much of your time. What is and why are you involved with the United States Medical Association?
Yes, so the U.S. Medical Association is a new startup 501c3 nonprofit physician representation organization. It seems like our leadership is overly entangled with the pharmaceutical industry, finances from pharma, their contractual relationships with the U.S. government for proprietary codes. You look at the American Medical Association, and they get more revenue from licensing CPT codes to Medicare than they get from all of their members combined. And so when you have, the Affordable Care Act being rolled out, and the government just has to say, hey, we're rolling out a reform, and we don't think we need your CPT codes anymore, or maybe we do, we'd like your support. And suddenly the AMA endorses a program without a single thing that helps physicians. There was not one piece of the Affordable Care Act that had anything that solved any of the physician problems. If you remember before that, we had the sustainable growth rate formula, the SGR, and we were facing 21% pay cuts in our pay every single year. And the AMA did nothing. You see all of our national corporations that are more beholden to dollars invested in their magazines from pharmaceutical industry than anything else. And it just seems like the physician voice has been lost. The patient voice is very heavily supported. There are many patient advocacy organizations, but there's nobody speaking for physicians. And so we have started an organization called the U.S. Medical Association that is a representative organization. So members basically will set the policies, and it will be a national advocacy organization for physician developing CME and content and educational materials by physicians and for physicians. So,
is there room for pediatricians in that organization?
There's room for everyone within that organization. And when we get that organization up to the size we need, we reach out to the specialty societies and ask for delegates from various specialty societies as well. So we'll have state representatives from the state medical associations, specialty society representation. So it will be a broad-reaching organization. So that's the United States Medical Association.
And will it lobby for a certain thing, or just, how will you set your priorities on what you're going to advocate for?
Yeah, so as a 501c3, we can't lobby for anything. We can certainly provide education, but that would have to be a separate entity. It would have to be, more like a PAC that you would set up as a separate entity, and that's something that's also in the works as part of this process rolling out. So, you look at the Florida Medical Association. I'm in Florida, so you have the Florida Medical Association. The FMA delegates create the policy. They create the guidance for where we want to see the state go, and that is the litmus test for all things legislative. So when a lawmaker says, we're looking at passing this, what does the FMA think? They'll reference the policies set out by the delegates, and then they'll know. But if they wanted to seek legislation or support candidates that are supporters of medicine, that's through the FMA PAC. That is a separate entity. That is an advocacy organization that lobbies, that supports candidates and so forth. So that same general concept.
And so how will you guard, because sometimes when you get this representation, maybe George Rogue was there, but he's representing himself and not really the members as a delegate. Will you have more direct voting from the membership?
There will be direct voting from the membership, and then there's also a board, and you can elect members to the board. So, you have the founding members of the board, of which I am one of the founding members. I am not the founding member, but I'm one of the founding members. And then the representatives that are delegates to the organization will vote representation as the board expands, as the organization grows. And so you'll sort of have checks and balances with them in the board and guardrails that are put on it by its membership.
Great. Well, thank you so much for sharing this time this morning with us. I will put in the show notes the links to the foundation as well as to your meeting and how people can reach out to you on LinkedIn in case they want to ask you questions. Is there anything else you would like me to put on the show notes?
Yeah, so you can add the website for the U.S. Medical Association. That's usmedicalassociation.org, usmedicalassociation.org.
All right. Thank you so much for your time. This is great work you're doing, and I know you're very busy, and I really appreciate you taking time off your calendar to talk to us today.
It's very interesting. Thank you very much.
Both of you.
All
Thanks
right.
for spending time on your vacation with me.
All right.
Ciao.
Have a great day.